Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Okay, so every now and again you learn a little something by listening to the radio. But if you listen to our program, you'll learn a lot about something every time you listen to the show. And, it's kind of like, listener-driven. Vein Clinics of Hawaii have been around for a long time now and started out on the Big Island and slowly moved through the island chain like the fresh trade winds. And then got here on Oahu, and then we started this program. We're in our second year now of getting together on a weekly basis with Medical Director Dr. Randall Juliff, and we talk about stuff. And mostly the program is designed to bring you up to speed on these little things in your legs called veins and arteries and everything else. And a lot of times we just assume that you're all sitting there on the edge of your chair waiting for your specific question to be answered. And guess what? We do have a way to do that, and that is by going to veinclinicsofhawaii.com and click on the link, on the Contact Us link. And that's what we kind of have for you today. And I think that this is going to be the start of a real new direction that we're going off in the program, and that is when you ask a question, it goes to the doc. Doc takes a look at it and decides, all right, this is worthy of really getting into, and that's what we're going to do today. Our patient's name is Liz, and she wrote a nice question. And Doc, you got the question, and here we go on a new direction on the program.
Yeah, I think it's going to be an exciting direction because we love to interact with people, and obviously sometimes it can't be real time. But yeah, we've got this way for people to go to the website and jot down whatever it is that they feel is the problem, and then we can address it directly or call them. Usually, I'll have somebody in our office call and answer questions and have them come in.
One thing I found, and we're going to do that today, I'm sure, is that there's no silly question.
Oh no!
I mean, and sometimes people self-diagnose themselves into a corner, and every night say, you know what, you do have a condition, but it's nowhere near as bad or life-threatening like you think it was.
Right.
Or the other thing may be true. You have a condition going on here that you've been not getting fixed for a long time, and it's time to get it fixed.
Right.
So what about our lady Liz? What did she have?
Okay, well, so this is her question, and it was a great question because it encompasses so many little different aspects of vein disease and vein care. Mm-hmm. But this is what she wrote. I am concerned about my husband. He's had vein surgery already where they cut out his vein because he had a vein that burst on his right leg. And then he had the left leg done as well for precautionary measures. The surgery was done about several years ago. About a month ago, he had what he thought was a pimple on his left leg calf area, and it stuck out, and it was like a scab. One day after his shower, the towel must have caught the scab, and his vein burst, and there was a lot of blood, like a huge puddle, and it was squirting all over, and we had to put pressure, and eventually I was able to get it stopped.
Wow.
The bathroom looked like a crime scene. So there is now a scab there again, and we are keeping it covered. Is this something serious, and is it something we should have taken care of right away?
We've talked about similar things in the past.
Oh, yeah.
And people, when this spontaneous thing is what you can explain, when that happens, people just have no clue. They run.
Yeah, right.
Well, I know this is a big concern, and it sounds like this is what you've talked about a little bit about before. Wasn't it sort of interesting that they made that observation?
He made the observation that
hey, wait a minute, this is not good.
Yeah, right. Exactly.
Yeah.
I have to commend them because they obviously did what they needed to do to make the bleeding stop, and we'll talk a little bit more about that. But yeah, you're right.
Yeah.
When you see bleeding, the thing to not do is to run down the street screaming, because there is a way to control it. But so anyway, starting from the very start of this question. We're going to take apart little comments that are made within the question, and we'll kind of investigate each little topic. So, the first thing that's interesting is that he had vein surgery where they cut out his vein, and I think the point there is that how we treat vein disease anymore.
Yeah.
Is a lot different from.
I was going to say,
what
do
we
you
used
even
to
do that anymore?
Yeah, well, we don't, and it shouldn't be done. Sometimes we still hear of that kind of thing being done. Very, very occasionally should this traditional surgical vein stripping still be done, but not very often because we've got so many different ways to handle it. But in the old days, when people did have surgical vein stripping, they were admitted to the hospital they were there 2 or 3 days. They came out with a bunch of incisions on their leg, a lot of bruising, and a fair bit of discomfort. And I think a lot of those people, unfortunately, kind of went home and laid in bed for a couple of days.
I can remember something, and I don't know if this is part of it, but I'm going to guess. And like I said, Gang, I get to ask questions. And sometimes I think they're pretty silly, but they're really not. But what I did learn in the previous program, Doc, is you said that in those days, when they did that opening up, the vein wasn't just laying there so that you could pick it up and remove it.
Yeah.
It was attached to a lot of different things.
Right.
So isn't that trauma?
Well, it is. The way that we used to do it is to make a little incision down near the bottom of the vein. And maybe one in the middle, and then another incision up at the top. And we used to tie off the vein at either end. And then we
tie it off because if you didn't, it's going to bleed.
Yeah,
okay.
Definitely.
Just checking.
And so we would literally thread a stainless steel wire through the vein from the area that we opened near the ankle, and ran it all the way up to the area that we opened near the groin. So it was the entire length of the leg,
which is a couple of feet.
Yeah,
3 feet or more sometimes.
Yeah. And so then we tied the vein to that little stainless steel, wire, and then we literally pulled the vein right out of the leg. It was traumatic.
Is some easier than others? To some, wow, this came out easy.
Yeah.
And some, wow, this thing's not coming out.
Yeah. Well, most of the time you had to tug pretty hard.
Yeah.
And it was traumatic in that that vein. It's not like it's a single tube. It's a vein, and it has a whole bunch of branches coming off of it. Yeah. And those branches were just kind of avulsed as we pulled that vein out. Now we controlled bleeding with pressure.
Good,
and typically it's not like it bled a lot, but they're much more bruising. Yeah. And as you
better in the operating theater than on the street.
Yeah.
Yeah, because you can stop it.
So the procedure that we do nowadays that has taken the place of surgical vein stripping is something that we call endovenous ablation. Now there's a number of different ways that we can ablate a vein, and but the vein stays in the leg. We just close it down. So that's accomplishing the same thing. The thing that we're accomplishing is removing the vein that is functioning abnormally, or taking it out of the circulation. Now when we took it out before, we actually took it out of the leg, but we're removing it from the circulation now by just closing the vein down.
Sure.
The problem with that vein is that the blood is going in the wrong direction. And so when we close it down, it eliminates that abnormal flow pattern, and it forces the body to reroute blood to normally functioning vein, and then the blood comes back up to the heart the way that it should. So, the way that we do it now is the patient comes into the office. It's completely outpatient. It's very minimally invasive. We don't make incisions anymore. We just make little needle puncture sites. I mean, we enter just through little needles, and we're able to close the vein down. We use a lot of local anesthesia, so we numb the leg up really, really well. And it's a pretty comfortable procedure. At the end of the procedure, we wrap the leg up with a little bit of gauze and put a compression stocking on that patient, and the patient goes on with their day.
And the good news is, gang, and just like our patient Liz in that question, is I rode that pony. I've experienced exactly what you just said, and it's the difference in treatment today and what it was like in my mom's era, like you said, when she spent a couple of days in the hospital.
Yes.
I had the same treatment, and I walked in and I walked out.
Yeah. And that's one of the hurdles that we have to get over often with many people, because many people who have vein problems, they saw what their parents or grandparents had to go through, and it becomes a blockade to them wanting to come in and have their veins treated. But so we try to educate people and let them know that it's a lot different these days, and much easier to get treated and get over the procedure.
Okay, now what did you call it? What we treated him for? I mean, it was a pimple that turned into a bleeder, and what did it indicate? What was it, and what did you do exactly to get rid of that problem?
Well, I think that when this patient, and again, now this is not, we haven't. Well, I wasn't the one that treated this patient. This patient was treated somewhere else.
Yeah, in the first place.
So so basically, I think what happened here is that 7-8 years ago, when that gentleman was originally treated, he was probably having symptoms. He probably had varicose veins, I would imagine, and he was evaluated and eventually got surgical vein stripping. So at that point, he was, probably for the most part fully treated for. I mean, we can only assume that he was fully treated for the problems that he had at that moment. But one of the problems with surgical vein stripping is that it never seemed to be done quite as completely as we like to do things today.
I get you. Okay.
So now he returns with problems now 7 years later, and now the story goes on. So the next comment is he surgery already he had a vein that burst on his right leg, and that she's talking about before. And a lot of people will use that term.
I was going to say burst. I'm not sure. Did it burst?
Well, I don't know. We don't know.
Yeah, of course.
Because
maybe.
And the reason I bring that up is because people with respect to vein problems, people use that term burst, and I think for a lot of people it means a lot of different things.
Sure. Yeah.
Sometimes it means that I have a spider vein here now, and I didn't have it 3 years ago. So it
must have burst.
Yes, right. Yeah. So a lot of people will, when they're talking about spider veins, say, a vein burst. And then another place that they use it is, and we hear this quite a bit, I had a little trauma. I got hit by a soccer ball, or I used to play soccer. I used to play football, and I got hit here and there. And people will say now, so now I've got this burst vein.
Yeah.
But on the other hand, it could mean something as bad as what eventually happened to this person, and that is that the vein actually did burst open and create bleeding. So it's kind of a wide spectrum of that term burst as far as what people actually mean. And when they use that kind of comment, then obviously we have to dig a little deeper and find out exactly what they mean by it. But obviously it in most people's mind, it has something to do with vein disease. And so we figure it out from there.
Yeah, and you know what? Further to that, gang, if you heard earlier in the question, Liz's question, talked about having the other leg done just in case.
Yeah.
And I'm thinking, I've never heard that. Hey, you know what? You want to go in there just in case and take something out. What but it stands to reason, though, right? I mean, why a person would come up with that question?
Yeah, well, that's the next part. She used this term precautionary measure. So the left leg was done as well for precautionary measures. Now, I think maybe in her mind it was precautionary measures, but the patient, again, presumably they also had significant venous insufficiency
sure.
or
in that leg,
reflux,
in the other leg too.
In that leg too, yeah. So, and we run into that all the time. Now, you're right. Do we do procedures on patients just kind of prophylactically, even if there's not an existing problem? No way. But often people will come in with symptoms that they don't necessarily attribute to vein disease, which is we see that all the time. When people have varicose veins in one leg, it's easy for them to say, "Oh yeah, well there's varicose veins. I have a vein problem in that leg." They may not have they may not have varicose veins in the other leg.
And by the way, I'm like that, right? I mean, I have more conditions in one leg than the other.
Yeah,
and I know that
exactly.
you've explained it before that there's some people, the legs are not identical. One leg is a big problem, the other one's no problem.
Yeah. We see that. But probably more often we see a patient that has fairly advanced kind of, superficial things like varicose veins, spider veins, even like discoloration and that kind of stuff. And the other leg, even though it has significant venous insufficiency or venous reflux, it hasn't gotten to that stage.
I was going to say it didn't manifest, so you can't really see it, right?
Yeah. So, and that's very, very common. It's very common that people come in with one leg a fair bit worse than the other. But then we have to question them a little more deeply about symptoms. And often they will have symptoms in that other leg, the not so severely diseased leg. And if they do, and if they have significant reflux, then we usually recommend that we do treat it, because it's kind of, vein disease just gets slowly worse with time.
Yeah, unfortunately, it's one of those. And isn't that sometimes why it's very, very difficult to really get on the treatment bandwagon? Because sometimes it takes some people a lot longer to figure out they have a problem than others.
Yeah. And that's what happens when two legs are kind of on a little different point in the timeline, because they might be having symptoms in the other leg, but the symptoms they're focusing much more on the more severe leg, so they're kind of ignoring the other
like
leg.
my right leg aches, but my left leg's fine.
Yeah, exactly.
Maybe not.
Often maybe not. But and then the other thing is that like we've talked about, the symptoms of vein disease come on so slowly and over a long period of time. It's kind of it's easy for people to ignore them for quite a while too, and chalk it up to aging or whatever. So this is not an uncommon occurrence where one leg is a fair bit worse than the other, but we treat the other leg if we find significant reflux. And why do we treat? Well, we treat to eliminate symptoms. We treat to avoid progression. We know that their venous disease is just going to slowly get worse with time, and we want to stop that. We certainly don't want those people getting into those higher clinical levels where they start to have, the skin problems with the darkening and the thickening of the skin, et cetera. We don't want them to get to that point. And then also the other reason that we do it is to eliminate the increased risk of DVT that people have with venous insufficiency. So those are the reasons why we might treat another, the other leg, the opposite leg that isn't quite as symptomatic or as severely affected by venous insufficiency.
Okay, and that being said, I mean, I also thought it was kind of neat that this patient and the wife had saw something that they thought was a pimple.
Yeah.
And you must get that described in a lot of different ways too.
Yeah, sure. So she mentioned something that she kind of visually thought looked like a pimple, and you don't know what that was. Who knows what that was? Maybe he had maybe he hit his leg and didn't know. We talk about all the time again with those more advanced stages of venous insufficiency. The skin of the lower leg becomes very affected. It can become much more fragile. And sometimes you can bump it a little bit, and you'll get a little cut in the skin or a breakdown of the skin that just doesn't heal.
Isn't it amazing? Not only does it not heal, but how they change and they get bigger and bigger and bigger, and people just sort of grow into treating that thing as it gets bigger and bigger for a long time.
Right, right. So maybe something like that. Obviously, something happened because it affected that area of the skin, and she described it as looking like a pimple. So maybe there was a little infection, maybe there was a little pus under the skin or whatever, and then the skin from there is probably just going to break down further. So now we're into it, again with this patient, we're into the potential of him now developing something that we would refer to as a venous stasis ulcer. And why is that important? Well, that's important because now we're definitely getting into those upper clinical stages of venous insufficiency. When somebody develops an ulcer, they become a stage 6 or a classification of C6.
That's the worst. I mean, it goes from 0 up to 6.
Right. Yeah. So we're definitely in those upper levels, and we start to feel a little more urgency in getting that patient treated, and we are expecting that they have a fair bit more venous insufficiency than the normal patient with just varicose veins and a little swelling.
You don't just jump to number 6 from 0. So that must mean that at some point in time, maybe things weren't symptomatic, but is it sometimes not uncommon to think that somebody skipped over a couple of stages, that they had a little thing and then now it's a lot worse really quickly? Don't they? In other words, it's not an evenly divided 6 stages.
No.
In time.
It's not an evenly divided 6 stages. Yeah, you're right. And it's also not everybody. Not everybody with varicose veins is going to eventually get to stage 6.
Gotcha.
Even if they're not treated. There's plenty of people out there who have venous insufficiency and varicose veins, but they never ultimately get to the stage where they've got skin breakdown. And
well, what about this? When you treat, say, me, and I'm a 6 because I've had these things, and you treat all of the things that made me a 6, do I sometimes fall back a little bit in that I'm maybe not a 6 anymore? I might be a 5 or even 4.
Yeah. Stage 4 is when you start to have significant
skin issues,
skin
like
changes.
Me. Yeah.
C6 is when you have an active venous stasis ulcer.
Gotcha.
C5 is if you have a healed ulcer.
Okay, so I'm a 5.
Yeah, so
yay, I'm a 5. At least I'm not a 6.
However, that does not mean that your level of your C4 level may not lessen a little bit. There's a couple of different stages of C4. And so can your skin actually improve? Can you get to the point where you've developed an ulcer? And can we treat you and can we get that ulcer healed? Absolutely. And why do we treat? Well, we treat so that you'll, number one, heal that ulcer, but also, number two, that ulcer won't recur. Because if you don't treat the underlying venous insufficiency, invariably, ulcers come back.
Yeah, but here's the good news, and I've experienced this. I had this one. It's a long story, so I don't want to get into it right this minute, but it was a bad one. And I've had one teeny reoccurring one after that. But I think that all of us that suffer that, when you know what it is, and you think, last time that big thing started out like this.
Right.
So, I mean, I can wait until it gets really bad and I go in on the gurney to see you, or I can make an appointment to get it treated or looked at.
Yeah. Well, and that, when after a patient has that kind of experience, they have the knowledge now to know that, gee, that's the way that other ulcer started, so I need to do something now, rather than, waiting 6-8 months and using, some ointment or whatever on it. And like yourself, I mean, if we address it early, then it's fairly short-lived.
Okay, gang, so if you're wondering who is this guy on the radio right now, it's Dr. Randall Juleff. He's the medical director from Vein Clinics of Hawaii, and they have 4 stores, 4 offices on 4 islands, and a great website. And this particular day, today, our program is based on a question that came in, and we'd like to invite you to do the same thing. So if you go to veinclinicsofhawaii.com, veinclinicsofhawaii.com, they will get to Dr. Juleff your question. And it can be as simple as that. Just make sure that you have a question and maybe something you want to hear on the radio or maybe just something that you need to get clarified on. I urge you to do that. Go to veinclinicsofhawaii.com. It's available 24 hours a day anywhere on the planet. So just think of that and remember that.
Yeah. And by the way, if Liz is listening again.
Hi, Liz.
Hi, Liz. And I don't know that we've actually seen her husband. So I would encourage Liz to give us a call because he definitely needs to have more follow up from this. There's no question about that.
Well, I want to make sure that when somebody hears the word pimple, they don't go outside to rake the yard. That they, this thing, whatever the description is indicative of something that really needs attention.
Yeah. Especially if you've had a history of vein problems in the past, like this gentleman did. So why do ulcers occur? Well, we've talked a little bit about skin changes, and what's happening there is that there becomes an increased pressure chronically within the venous system. Veins in our legs should be carrying blood upward back to the heart. And when those veins fail in their function to do that, then the blood starts to settle downward in the leg. And ultimately, if it goes on for a long time, not only does it turn into varicose veins and swelling, but then eventually it starts to affect the skin itself. The skin becomes sort of the end organ in this situation of this chronically increased pressure within the veins. And we call that venous hypertension, just like arterial hypertension when people have high blood pressure. So the same sort of setup occurs within the veins, and what happens is that fluid and inflammatory kind of molecules, et cetera, leak out of the venous system and go into not only the soft tissue below the skin, but into the skin itself. And when that happens over a long period of time, then the skin, from this chronic inflammatory process, chronic inflammation, then becomes thickened and rough and fibrotic. It's like scarring to the skin. And eventually it leads to a lack of oxygen at the level of the skin, and that's why when people then bump their leg or get it cut or whatever, in this case, he had something that looked like a pimple, and the skin then is not going to heal because it's fibrotic and it's lacking in oxygen.
Then can't rejoin. Somebody had listened to one of our programs and brought this up to me. I forgot to pass it on to you, but this is what happened. He thought that his legs, he was a construction worker, and he also was a canoe paddler, and he was active, and he was constantly, what he thought, sweating. His legs were sweating, and so he would just towel it off or rinse it off. But it really turned out to be later on, once he heard the program, he went to his doctor and found out that he was weeping liquid. His leg was expelling liquid. It was not sweat.
Right. And that can happen. We see that, not uncommonly, where there's so much excess fluid in the soft tissue because of that venous hypertension, and that it actually starts leaking out through the skin. Yeah, it's an incredible kind of thing.
So that's just leaking out. But what you're talking about with this guy, whether it's a pimple or a sore or whatever, it actually, that vein, it does burst at the end. Or isn't that? I mean, I don't want to use the term.
We're talking.
But it's open, I should say.
Yeah, at that level, the little tiny little, we call them venules, at the level of the skin. I mean, we're talking about kind of the microcirculation. So it's not like a big vein that's failing or a big vein that's going to burst or something like that. But these are the tiny little veins within the skin that the I guess the integrity of those tiny little veins within the skin becomes abnormal. The integrity is lost because of that chronic increase in pressure, and that's what therein lies the problem. But so we get concerned about ulceration again because it's it's the end stage of venous disease. Now, the other point to be made here is that there's a variety of different reasons why people might develop ulcers on the lower part of their legs, ankles, and feet. Usually it's either a vein problem, it's an arterial problem, or it's people with diabetes. We call them diabetic foot ulcers. So those are the three main reasons why people develop ulcerations or chronic sores in the lower leg and ankle and foot. And if you have something like that, it definitely needs to be addressed. It needs to be evaluated, and we can help people sort that out. Now, I will say that of the people out there with chronic ulcers in those areas, lower leg, ankles, and feet, most of them, the majority of them, are due to poor vein function or something that we call venous stasis ulceration. So, we like to see those people because it's so gratifying to us because we can really impact the course of the health of their legs. I mean, they come in with these ulcers that have been there for months, sometimes years, and they've been treating them at home with topical stuff and bandaging, and that for the most part might control them. But often they don't get healed. Sometimes they even will get healed, but if further steps aren't taken for evaluation and invariably intervention, then again, like I said before, those ulcers are going to come back. So, and we can sort that out for them. If they have an ulcer, it may not be venous, but we can evaluate them for arterial problems or whatever. And if we can't do something about it, then we can get them plugged into other physicians that will be able to help them.
Yeah, and I do know that you spend a lot of time on wound care. And that in some respects, this becomes from a little pimple. It becomes as big as around 3 inches around.
Oh, yeah.
Sometimes I've seen it if you go to the website, gang, or you go to the office, Dr. Juliet's office, you can see sometimes these ulcers, they go right around the leg. I mean, you have a gap in your skin.
Yeah, they've got a very typical kind of appearance. They've got kind of an irregular border. The base of the ulcer is rough, and sometimes it can have a scabby kind of material on it here and there. But they can get huge. Yeah. They can get huge, and again, it's so gratifying for us to immediately institute wound care. Mm-hmm. And then go on from there to evaluate people and do the interventional stuff that will actually get them healed over a surprisingly short period of time.
Yeah, and you know what, gang, this is monumental because I can tell you from personal experience, we put up with a lot of stuff for a long time, trying to downplay its significance. You are at a pretty critical stage in your veins if these things are happening, particularly if one goes away and you get it fixed and another one comes right back after that.
Yeah. And then just the secondary problems like infection and that kind of thing. It's not something that you should fool around with, that's for sure. So then the next part of her question is, after his shower, the towel caught the scab, pulled it off, and the vein burst again. Yeah. So in her question then goes on to, she wonders at the end, is this a serious problem? And it is.
I should say.
It's
sure was with me.
Yeah. And what's happening there, again, it all has to do with the increased pressure in the vein. And most of the time, what we see is when people have spontaneous bleeding, we call that spontaneous bleeding. Usually what we see is a very superficial, and often it's sort of a spider vein. It's not a varicose vein. It's not it's not a big vein that's deeper in the leg, but it's a fairly small spider vein. that becomes very, very superficial by definition.
But you know what?
Veins.
You've said in the past, and maybe people could get this. Why does it happen a lot of times in the shower?
Yeah.
And especially a hot water shower. Maybe that's got something to do with it.
Yeah. Well, and I think it has to do with just the fact that the skin, these spider veins are very, very superficial. And as
meaning close to the surface, right?
Right.
Yeah.
And as the pressure makes them dilate more, the skin overlying those tiny little spider veins become thinner and thinner. And I think with the hot water and whatever, the skin just kind of breaks down completely, or a scab comes off, as she described. And, bleeding occurs. And sometimes the bleeding can be substantial. I mean, there's no question about that.
Scary, isn't it? A lot of people freak out.
It is, yeah. And so often we hear that scenario. I mean, it's such a common scenario where it happens in the shower, and which makes it even worse because they're standing in the shower and there's water. And it starts to bleed, and the blood is mixing kind of with the water. Makes it look like
it's like
worse.
Psycho, No,
Exactly.
wait a minute.
Exactly.
But isn't it interesting because what you just said a few minutes ago when I rudely cut you off was that it maybe happened with the friction of the towel going over the scab there, and then it's like. Is it amazing how much blood can come out of one of those little spider veins?
It is. Yeah. It really is.
What makes it stop?
Therein lies the question.
Yeah.
So, if this is something that happens to you or a family member, the thing to do is to, rather than, like running to the car or something, the patient should lay down, elevate the leg, and put pressure on that area that's bleeding, and typically it's going to stop.
What do you do after it stops? You don't just say, well, that's over.
Yeah, no, you need to be evaluated from there. But, the thing is that even though when we're standing up, that's when the pressure is highest on our venous system, on our veins, because gravity is pulling that blood down, through our venous system. And so when we're standing up, there's a lot of pressure on those tiny little veins.
That's what I was asking.
And
because you're standing up for 10 minutes in the hot shower.
Yeah, exactly. Yeah. And that's why so much blood can come out. So what we want to do is we want to reverse that. Well, the way that we reverse that is to elevate the leg. Now, the good thing about the venous system is that it's not a high pressure system typically when it's functioning normally. And then also, if you elevate an extremity, the pressure in that venous system is going to decompress immediately. So it's going to make controlling that bleeding a lot easier. So the way to do it is to, if you're alone, lay down, try to get your foot up, and then in some way put pressure on that specific site that's bleeding. And or if you're with someone, then the patient should lay down flat, get the leg up as high as you possibly can, and then the person that's with you can apply pressure, and it'll stop.
Okay, now depending on the size of that, I did notice in my notes that every now and again somebody says, even though you tell somebody not to go rush into the ER, a lot of people are going to do that, and when they get there, I mean, if it's been bleeding for a long time and it hasn't stopped, what do they do at the ER? Give you stitches, or what do they do?
Well, probably the same thing immediately. But do I think? No, that's it's a good question, and I think that people have to kind of play that out the way they think is most appropriate. I think if they're anxious about it, they probably do need to go to the emergency room. But the first thing to do is to control the bleeding, at home before
and it will stop.
It'll stop, and then you put a compressive, pressure kind of dressing on it, and then you hop in the car and go to the ER, preferably with your, foot up. But so in the ER, what are they going to do? Well, there's a couple of different things that I've seen emergency rooms do for spontaneous bleeding. One of them is to put a stitch in it, which is fine. I mean, that whatever's going to get it stopped, and whatever's going to get it, stabilized. You don't want to just, put pressure on it and then send the patient home, because probably it's going to happen again. But so a couple of different things are to put a stitch in it, or there are hemostatic products that you can apply to a bleeding site like that will help, coagulate that area and get it to stop. If the patient doesn't mind keeping a pressure dressing on that all the time, that would probably be fine too.
I got you.
But probably the safest way to do it is to go to the emergency room, have somebody put a stitch in it, and then the patient needs to go somewhere to be evaluated for it.
And by the way, that evaluation, when it comes time to Vein Clinics of Hawaii, often boils down to an ultrasound examination. And what I want you to do, in case you're just wondering, you're listening to Dr. Randall Juliff. He's the medical director of Vein Clinics of Hawaii. And this is today's program. It's a patient question. Liz is her name, and we've been talking about what happened in her family with her husband. And as you've been learning, just in the nick of time, they noticed something was going wrong, and you're learning the ways to do something about it. The point I'm trying to make is if you want something answered on this program, you can go to veinclinicsofhawaii.com and click on the More Information button or on the Contact Us button and get in line. And we're happy to do this. As a matter of fact, I know, Doc, you appreciate this. The more we hear from the different people out there in the listener base, they're also in varying degrees of a patient base.
Sure. Yeah. And I'm not sure whether they did go to the emergency room.
Yeah.
It seems like maybe they didn't. They just controlled it at home. But, I think going to the emergency room and having a little bit of professional help with respect to stabilizing that site is a good thing. But the key to it not happening again is going to be, again, treating the patient's underlying venous insufficiency. So, we want these people to come in, see us. We can, figure out exactly what's going on with their venous function and then go from there. The key is to eliminate that venous hypertension, which is what's accomplished when we do the things we do.
Now, generally speaking, though, if you go to the ER, there's not, while I'm here, can you look at this? Can you look at that? What you're there is for that trauma, right?
Yeah.
But that would be indicative of if that happened, there's more things going on in your system that you need to know about.
Yeah, and typically hospitals don't. Especially the emergency room, they're not really equipped to evaluate venous hypertension completely, the way that we do in the office. So that's why it's kind of, you go to the emergency room, you take care of the immediate problem, and then the next step would be to, give us a call and we'll go from there. So we treat the underlying venous insufficiency, we eliminate that venous hypertension, and then we monitor that patient in the future to, monitor them closely to make sure that things don't recur in a way that might allow that, bleeding site to open up.
Yeah, you know what, gang? Once you find out where you are, that's what I say often is that if you have a history in your family or some of these symptoms, and one of the things that you said interesting earlier when they used the term burst, it also made me think of some other things that go on when people are explaining their symptoms and what one condition can mean to one patient a symptom and another one different. In other words, somebody say, well, it's numb, or it's tingling, or it throbs, or it hurts, or it burns. It's the same problem. Yeah. Isn't it that we perceive pain and discomfort differently?
Yeah. Well, differently, and then also, vein disease just in general presents in so many different ways.
Yeah, exactly.
And, one person may present with, tremendous restless leg syndrome. Somebody might present with spontaneous bleeding, that kind of thing. So,
but isn't it interesting, though, Doc, that clinics like yours and others exist because a lot of medical practitioners in other fields realize how specialized it is, and that you really need to go to somebody that's got not just the diagnostic equipment, but the right tools and the right stuff to help you investigate it and cure yourself, help yourself.
Yeah, right. And that's what we try to be. We try to be that those people for that kind of problem. But so her last comment in question is the scab is there again now. So it sounds to me like they controlled the bleeding at home. And it seems like maybe they didn't, go to the emergency room or even maybe see their, doctor specifically for that problem. But the scab is there again now, and we're keeping it covered. is it serious? And I think just from what we've talked about already, yeah, it is. It's a serious problem. Spontaneous bleeding is one of the two things we. When we talk about how urgent we should try to do something to intervene, our urgency, meter goes way up when people either have an active ulcer or spontaneous bleeding. We need to intervene quickly. So, this patient, this gentleman, definitely needs to be evaluated, and there are things that we can do to make sure the spontaneous bleeding does not happen again.
Yeah, and gang, let me tell you something. You get such a feeling of relief. I mean, I've talked to so many different patients when I'm down at doctor's, Honolulu clinic, that they feel. Actually, they're being a part of it. In other words, it's not a mystery that you just lie there and somebody treats you and then you leave, particularly when you do things like get the ultrasound, because usually the technician that administers is proud to show you what he or she can show you. This is your leg. Mm-hmm. And that's not an opportunity that many of us patients get in anything.
Right, yeah.
I mean, right now, if you go to a dentist, you see that instant x-ray. That never used to be.
Yeah. Well, that's true, yeah. And we like to do that. We like to get the patient kind of involved in their own care.
Sure.
Because I think, they need to be, number one. Number two, it makes so much more sense to people when we show them those kind of things, because then they start to understand what's going on. And then it also helps us in describing to them what they need, because, if they understand the problem, then they're going to understand the intervention that we're, proposing for them. So to kind of recap, is spontaneous bleeding a definite problem? Yes. It usually has a venous origin. It needs to be addressed immediately at home, and you do that with elevation and pressure. And then, once you control the bleeding, you may or may not want to go to the ER. That's a decision that I think each individual patient can make. Then you need to be evaluated from a venous standpoint. And you need, invariably, these people need some sort of intervention. There's no question about that.
What about the other side of it? And then this what we were talking about with Liz's husband was a spontaneous event. Mm-hmm. But what about a traumatic event? In other words, a lot of people think I just severed my artery or I just cut my vein. Yeah. I don't think most of us know what a vein is and what an artery is if you get one cut. But isn't it also a problem if you do get a laceration or a cut that there might be something very serious in that? It's not something you can't just put pressure on, put a Band-Aid on, and think it's going to go away.
Yeah, especially in the lower leg. Mm-hmm. Yeah, that concept would apply. Yeah. Because, venous insufficiency and venous hypertension is such a common problem. Yeah. 50% of the adult population has some degree of venous insufficiency. So if you cut yourself in the lower leg and there is that increased pressure within the venous system, you are going to have a lot of bleeding. Yeah. And it may be a little more difficult to control than it otherwise would. But the arterial... luckily, major arterial structures are deep, within a limb or whatever. Yeah. So
getting a superficial cut is probably not severing an artery.
Typically it's not, other than the tiny, tiny, tiny little arteries that are near the skin. But if venous insufficiency and venous hypertension exists, veins are right there. Veins are at the level of the skin, and if that pressure gradient is there, then a little cut's going to create a lot of bleeding.
Okay, in when somebody is harming themselves, when you see somebody cuts their wrist and lies down in the bathtub, right? Isn't there something about that they learned in a suicide book or something? But isn't that a very, very bad event?
Sure.
And if it's particularly, if it's accidental, what do? This needs to be looked at right away.
Yeah. Well, and I think with respect to where arteries are located, the reason why people, cut themselves at the wrist is because the radial artery is pretty close to the skin.
Gotcha.
That's one area where it is very close, and I think people have just learned that that's if you want to do it, that's the place to do it. But typically arteries are a fair bit deeper, except in that location.
Okay, now obviously this lady Liz and her husband going through the experience that they did and the answers that you've given. I guess maybe a dermatologist once told me a long time ago to check your birthday suit on your birthday.
Yeah.
I thought that was pretty clever.
Yeah.
But when you talk about monitoring, I guess everybody needs to be monitored at a different. But isn't these part of the parting gifts that you give a patient is, okay, you're up to speed. The treatment plan we did, you've been treated to where we wanted to have you. How often do you need to get followed up for venous conditions?
Yeah, the follow up and the long term monitoring is something that we try to do better than we used to. 15, 20 years ago when we were treating this kind of problem, mainly in the hospital with surgical vein stripping, et cetera. The mindset back then was, okay, we did an operation, we fixed you, see you later. And
but wait. I know I have one going on right now, and we're going to talk about this. Well, we could talk about it for a minute anyway, and that is something that we know is going on with me, but it's not screaming for attention. It's not to a point where I need to have surgery.
Yeah. Right.
But there's a way you can keep looking at it and check it.
Sure.
Which I've just done. I said that because I just went through a 6-month deal, and it's because of the record keeping that you do at Vein Clinics of Hawaii.
Yeah.
It's easy to see, well, you were here 6 months ago and you're here today. Here's what's changed. Or here's what's not changed.
Yeah, exactly. Yeah. And that's exactly what we do. Yeah. So we try to do a much better job with that these days. And so typically our typical follow-up, depending on where the patient is in that clinical scale, will sort of determine, how frequently we might want them to come back.
Gotcha.
We do ultrasounds. We call them surveillance ultrasounds, which are, just kind of follow-up ultrasounds to see, how the patient is progressing. Make sure that what we've done, 3 years ago is still stable, or whatever. Make sure that there isn't anything new coming up. If there is something, then we assess, do we need to do something about it, or do we just follow it? And that's what happened for you. You came in for your 6 months. Yeah. And you had a few little things that were sort of were inconsequential, for your overall vein health at this moment. And we said, we'll probably just check another one in 6 months and go from there. Yeah,
what I did learn though is to be a good guy and wear my compression hose, do all the right things to be sort of proactive in. I think maybe, and one of the best things about what we're talking about here is the answer can be multifold. So when somebody just needs to be looked at or somebody treated. Now, we've talked real quickly before we run out of time on this episode of the program. There are certain things in your office that are done electively. These are cosmetic procedures that are done, and your insurance company wishes you well but doesn't pay.
Yeah.
But what about when you want to get re-examined? I come in, say, for a checkup 6 months down, which is going to involve an ultrasound. Does my condition have my insurance company approved that I have that test?
Yes.
Yes, that's really good.
Yeah. And we make sure that, we make sure that those, insurance coverages are in place because we don't want people getting big bills for stuff that, they come in for. So, but it depends on on the clinical status of the patient. If the patient is one of those lower, clinical classifications, often we'll just do an ultrasound maybe every year, and but I think it's important for virtually all of our patients to have some form of follow-up because in the past we didn't do follow-up very well, and we see all of those patients now coming back with more problems.
Yeah, and incidentally, and that's because it's a condition that, unfortunately, thanks, Mom, in my case, it's all genetic. Yeah. But it is going to get you. I think the other side of it is, though, because of the diagnostics that are available, that people can actually, it's not, I know that you get asked, can I change my diet? What can I do to slow this down? Isn't it just, you just really have to keep monitoring it?
Yeah.
There's not a lot of things you can do.
Right. Yeah, there's not dietary changes you can make. There really isn't even, physical activity or exercises that you can do to reverse venous insufficiency. Now, does muscular activity and exercise, does it help vein function while you're doing it? Yeah, but at the end, when you stop exercising, you still got venous insufficiency.
But by the way, gang, don't think that, okay, great, I'll just keep my diabetes and I'll do this and I'll do that. Because no matter what, if you take care of that other stuff, whether you're diabetic or obese or whatever, your circulation system is going to be pretty happy.
Yeah.
It doesn't have to work as hard, does it?
Right.
Okay, remember, veinclinicsofhawaii.com, veinclinicsofhawaii.com. You can jump online and do what our Liz did and ask a question. We'll be happy to get it on the show and answered for you. So it's once again, www.veinclinicsofhawaii.com, veinclinicsofhawaii.com. We'll see you next time. Have a great day.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.